minutes, so hopefully this talk won't help what the food is already helping with our 8 minutes. But I'm going to talk a little bit about hip arthroscopy, and I think this will help the food digest a little bit. We can go into each one of these causes of hip pain to really help us understand what's going on. But I thought instead maybe we'd focus it down a little bit to some of the more common causes of hip pain. And I'm going to actually narrow that down a little bit more for us. So we're going to more talk about just the snapping hip, two kinds, internal and external, athletic pubalgia, labral pathology, impingement, and we'll stop there. The hip joint, we'll just go over a brief anatomy here. Hip joint is known as ball and socket joint. The main things we're really interested in today is the interior structures of the hip. Most notably the labrum, which is the gasket that goes around the hip socket itself, helps seal up the hip joint. It helps with some of the biomechanic stability and so forth of the hip. Inside, obviously, we have the synovial cartilage, and then we have the bony anatomy coming down the neck, surrounding musculature as well, including the iliopsoas muscle, which is key. So the first thing that I like to do with hip is really how do we differentiate the different types of hip pain. About 70% of what I do is actually just listening to the patient. I get a pretty good idea of what their hip problem is just by talking to them with a good history, asking about the mechanism, how did they do it, was it idiopathic event, what makes it worse? That's a huge one. Sitting makes it worse, high flexion activity, getting into and out of cars, always a bad one, running, twisting. Then comes zingers. And zingers I use as a term is kind of more mechanical instability, because people will talk about all of a sudden I walk, I twist, boom, I get sudden sharp stabbing pain, my eyes get wide, and then those fall down. So that gives me a little history of something more mechanical. And then of course you ask, where is it? If it's up towards the back, towards the front of the hip, and then kind of relate that with where these areas of pain should be. Go under tenderness. If it's tender to the touch, I can't touch inside the hip joint. If I can't touch the labrum with their tender, either it's an associative factor or something else is going on. And then the last 30% come with exam and injury. Exam, I'm used to really use that to substantiate what I'm already thinking is going on with the history, and try and say, hey, do these maneuvers make sense? Does provocative maneuver for this make sense for what they're telling me that they have? And finally, I'll say, well, let's see if the imaging studies also are in line. And then if I have all three of my ducks in a row, that helps me be pretty happy that my diagnosis is correct, and then I can go along with the treatment plan and what I'm going to do next. This is the general areas of hip pain, so it's kind of difficult. A lot of these areas really overlap each other. Arthritis is just general areas. Some have pain in the knee, some have pain in the back, some have pain in the front of the hip, back of the hip. My main landmark is I always use the ASIS, and that's when I ask people where their pain is in relation to that. Typically, labral stuff is usually just inferior to that. A lot of people do the classic C sign, but most will kind of point towards the front and say maybe it kind of stabs towards the back, but it usually always starts somewhere in the front. Athletic pubalgia, osteitis pubis, a little bit more medial to that, as well as the iliopsoas and snapping hip. They'll point a little bit more towards the interior thigh. So let's talk a little bit about labral tear. Causes hip pain. Like I said, this is the one that's mostly just inferior to the ASIS. They say it's right here, doc, but it's deep. I can't touch it. It's kind of aching. Sometimes it goes right to my butt. And one thing I've heard from a couple patients, it feels like I'm sitting on a golf ball. They just can't get comfortable. They get that ache in the butt, kind of sharper pains more in the front. Also, just the combination. It can go in different areas. Different things can exacerbate it, make it more painful, including pivoting and twisting. That's where they may get a zinger if it's an unstable type tear, but that really just depends. History of trauma, well, you get an athletic person like this, yes, it can be traumatic, but I'd say more often than not, most of the labral tears that I see are atraumatic, coming from different various pathology. Usually worse with activity, better with rest. But what do you consider rest? You consider rest sitting down in high flexion. Well, that makes labral tears worse. So it really depends what type of rest. So, how many people heard about hip arthroscopy? People know people that have had it? What about this guy? People know Marcus Aldridge? All right, well, just in the past month, here you have him just had surgery on his right hip, had a labral tear repair. You go to A-Rod, there's a ton of athletes out there that now bring hip arthroscopy really to the forefront of the news, the media, and the rest of us, which is nice because, 5 years ago, people wouldn't see me for 5-10 years. I'm the third or fourth physician that they'd see because everyone said everything's fine. How do I diagnose it? The biggest provocative test is a flexion, internal rotation, adduction maneuver. There's a video I'll show you later in this, but basically this type of thing. And I really don't even ask them anymore if they're having pain. When I do it, I just watch their face. They're always wincing, and you don't have to ask, you'll see it. And then with that, you do circumduction, which kind of a grind test, same thing. Just watch their face, and you can tell how much pain they're having. If they're just kind of up in flexion, pushing down, that's kind of one thing I'll do to kind of differentiate a little bit of dysplasia, because some of those are difficult. Problem is, this is not very specific. It's sensitive, but it's not very specific. There's a lot of things that have pain. Besides examination, imaging studies, a couple different ways to do it. Diagnostic hip injection. These I do with people who just the history may not quite make sense. They may have other things going on, spine problems, back problems, knee problems, tendon problems, differentiating pains that come from inside the hip or outside the hip. So we'll inject inside their hip with some local medication, maybe with some steroids, and see if they have some relief. Really make note to see if how they feel within the first after. It's tough to do it if you're, I usually don't do them with an arthrogram anymore. I used to do it at the same time, but the arthrogram is so painful because it's such a hypertonic solution. They just feel uncomfortable. They can't tell you whether it helped at all. MRI arthrogram, here's an MRI arthrogram. You really need an MRI arthrogram to see if the labrum is torn. Non-contrast MRIs may show a paralabral cyst, but it's really going to have a very hard time showing a torn labrum. Even with an MRI arthrogram, it's not as sensitive as I want it to be. Clinic patients, I see the completely normal arthrogram. When I go inside the hip, it's like this, and it's just trash, and there's tears all over the place. You say, how did that have a normal arthrogram? Finally, hip arthroscopy, really good. The other common one we see more often is internal snapping hip. Usually common in younger athletes. You're going to see a lot of this down here. I've treated some of the high-level soccer players down here, gymnasts, with this type of thing. A lot of ballet dancers have it. Just because if you have it doesn't mean you need surgery. A lot of people, and the vast majority of my patients, if I have them do active circumduction of the hip, rotating the hip around, I can get them to pop their hip. If they're iliopsoas tendon, that's normal. But it shouldn't be painful. Diagnosis also, I think Dr. Moore talked a little bit about ultrasound. Well, you can also do with bursography, so this can be done under fluoroscopy, where they put dye in iliopsoas tendon, have them rotate, do circumduction of the hip, and you can watch it pop over either side of the femoral head. So the big thing is how do you differentiate between the two, because they are very similar, they're similar in presentation, but you got to kind of listen to key things. Location, it's a little bit more medial in the snapping hip. Prolonged flexion and the labral tear due to impingement. Well, this is worse with kind of repetitive flexion. The iliopsoas is going to usually have more popping, but you can have popping with labral tears. Physical therapy usually makes the labrum worse. But a lot of these things, as we see with the anatomy, the problem is the iliopsoas tendon runs right over the labrum. So it's within a couple millimeters of the labrum. So a snapping tendon can also cause or irritate a labral tear. So you get all these confusing pictures. Again, just dancers, soccer players usually will kind of bring this a little bit more to my attention, especially female people. Sports hernia, this is another difficult one that's commonly confused with everything else. And the problem is it's just because it's poorly understood and defined. I still have general surgeons that are kind of at the top of their game about this stuff, and every time I see them in the OR every month or so, we talk about patients that are similar and you can't figure out, you can't tell whether it's a sports hernia, and I can't tell whether it's a labral tear. This is kind of more or less a diagnosis of exclusion. It's very difficult to figure out these patients. You just got to say they just don't really quite fit the picture. Maybe diagnostic injection doesn't work. And send them to someone who knows a lot more about athletic pubalgia than myself, like a medical surgeon. A little bit of difference between the two. Again, they can overlap quite a bit, but certain things that are going to make athletic heat valves worse, all solid pain, pounding, females in pregnancy. There's certain things that you're going to kind of say, hey, this is maybe leaning a little bit more this way, so maybe we should try to diagnose this a little bit more. This is a big thing nowadays, femoral acetabular impingement. Lots of people have surgery, including this guy. Presentation, it's very similar to labral tear. We're essentially looking at the same thing again. Impingement begets labral tears. So how do you really diagnose femoral acetabular impingement? Really, it's a little bit of examination because the motion of the hip, but really it's a radiographic diagnosis more than anything. More of a chronic pain, so these are people that don't have a specific sports injury. There's no traumatic event. They kind of just say, hey, it's been going on for 5-10 years and it's getting worse, and when I'm sitting in the car, high flexion, it just seems to keep getting worse. On motion, they're going to have limited internal rotation and flexion. So what is it? It's from overgrowth of bone and pinching on the range of motion of the hip. There's two main causes that combine. This is kind of a representation of the normal, where you have a head with a scalloping down to the normal neck, represented in here. Basically, at some point, ball and socket joint is going to impinge. The neck is going to impinge on that cup at some point. So there's two ways for it to impinge: from overgrowth of the cup, which is going to impinge earlier, or there's overgrowth of the neck, which is going to cause the impinge earlier. And that's represented with the shaded here, and then the combined area. This is going to cause our damage. That's going to come up and whack our labor, and whack our cartilage, and cause problems. These are x-rays. So here's an easy representation. The white line that I've drawn in there is what it should look like. That's where the contour. You look down here, there's a nice neck coming with a nice inferior contour. Should come up and do the same thing. And you have this huge ham impingement lesion. Now this is a lateral hip, so you can understand that this is the, when someone's walking, this is the anterior part of the hip, so when they're flexing up, that's why it's sitting right here. So, but we see it on the lateral because that's how we get our x-rays. This is our after arthroscopic procedure, where we basically recontoured that entire bit of bone and made it look normal again, made it function more like a normal hip and socket. We can see it on MRI as well. Big bump here, labrum up there, it's white, it's attenuated, it's irritated. The acetabular, we talked about the other side, well, it's overcovered. Well, we look for a crossover sign on the x-rays. A normal hip should come down. If you don't look at this, normal hip should have anterior wall, posterior wall. They should intersect at the top. They shouldn't intersect anywhere down the middle. That means the hip's actually rotated towards the back, retroverted. That's increasing coverage over the anterior aspect, which is giving us our pitching, which causes our damage. Ossified labrum, a little bit here. This is an accessory called os acetabular. This is a piece of bone that I see commonly in people with really bad impingement. So if they have a big cam lesion, you can tell this guy already has it. He has a little bit of pistol grip forming here, seen on the AP. You put him in the lateral, you're going to see a huge impingement like the other one. Over time, and I think just growing up, involved with the ossification centers, this part never ossified, never came into the bones. You'll see these big hunks of bone that when you go and see them surgically, they're unstable, they're painful, the labrum is attached to them, and you can see why they're having so much problems. So how else can we measure the impingement? We use something called an alpha angle. Alpha angle is just kind of looks for the aspherity of the hip joint, and it's kind of difficult to understand, and these are two pictures I've taken from a radiologist in Portland who told me that this alpha angle is 79 degrees. 79 degrees is a huge cam lesion. Well, he's under the impression that the line stops where the aspherity stops. This is wrong. This is right. It's the alpha angle is when the circle stops. This guy's alpha angle would be more like 25 degrees, not 80 degrees. This is an alpha angle. Line down the neck, make a circle around the head. When this line of the femoral head and neck comes outside that circle, that's where you put your angle. So that helps us. We usually like to see something below 50 degrees. So this is huge. This is how I get my special x-rays. Really nothing special about it, but bring the hip up into flexion, rotate it out externally, and then shoot the x-ray straight down. That gives me that nice contour at the head-neck junction, gets the greater trochanter out of the way so I can really look at the contour of the neck of the hip. So here we look at, again, labrum versus FAI. How do I differentiate the two? very difficult. They're often seen together. Limited internal rotation is one thing I'm obviously going to see here, and people always tell you, Doc, I've always been stiff. I've never been as flexible as the other people in high school. Abnormal fingers, they can't really sit with their knees all the way down, cross-legged style. Their knees are always up. And then, of course, we have x-rays. If I see this in someone with pain, I think, oh, it's probably just a labral tear. I don't see any impingement. If I look at this, it's probably a jewel. So hip arthroscopy, let's get into more of the fun stuff with your warm up. So this is the hip arthroscopy. It gives us access to the hip joint. It gives us a cool view. We use a 70-degree scope through small incisions. This is the femoral head itself. You got to look at a nice view of the cartilage here. It looks perfect. Pop back into the central compartment. Oh, here's our labrum up here. Here's a big tear. Okay, cool. Let's look around. The rest of the cartilage around the socket looks fine. The back of the labrum looks fine. Now we're in the caudal fossa, the very central aspect of the hip. The ligamentum teres there. You know, his cartilage looks fine here. This is the main problem. The labrum, as you can see, comes back this way. Actually looks okay. There's no big tear right at the junctions here, like there was in the anterior aspect. So that's typically where the tears are, where you saw it before. Labral pathology, acute versus chronic, again, it just depends on the timing of it. I have two options, to breed it or repair it, and that just depends a lot on the patient, how long it's been going on, what does it look like, does it look repairable, kind of like a meniscus, right? You know, if it looks shredded, if it's in the right spot, maybe we'll repair it, maybe we'll just have to clean it out. How are the outcomes? It really depends on, again, patient, how much mileage is on the hip, how does the hip itself look. Here's a huge labral tear in this guy. Like we said, they said, you know, usually these things can be acute from sports injuries. Well, this guy's injury was a sports injury, and he better with his life. You know, a big tear here. He also has some cartilage delamination, but you can just see how huge his tear is. You know, that's a big problem. So what can I do? Here's his labrum after I've kind of cleaned up a lot of the areas and the delamination under the tear. So the labrum I have free. I cleaned it up. I prepared a bone bed here where I'm going to put it back down to the rim, restore that gasket, restore that suction seal inside the head of the probe right there. That's why I wanted to look at the end. So we're going to try and put some anchors in here. I try and get it as close. Here's my bone. Here's the cartilage. You know, a few millimeters of cartilage. I try and put that anchor as close to the cartilage as I can because obviously if I put it too far back on the rim, then I'm not doing what I'm trying to do, which is put that, restore that gasket right on the edge. So I use 2.3 millimeter anchors. They're very small, which again allows me to get as close to the articular surfaces as possible without violating the cartilage of the joint. So the anchors I typically use are PEEK, so they're not absorbable, but they're kind of like a bone itself. We don't see them on MRI, and they have great fixation strength, Kevlar stitch, and they work great. So there's our 2.3 millimeter anchor in there, and then basically, usually I'll try and loop it around the labrum. This one was a, you know, I think a 25-year-old actually had a pretty shredded labrum, but in her case, we really wanted to try and preserve it, so we have already an anchor in here. We clean up the edge. Just do some suture techniques inside the hip to suture back down and restore our seal around the hip. Cartilage injury inside the hip. So a lot of times this is something I see with the bad cam impingement lesions. This is the time where that just constant pounding of hip flexion causes problems inside the hip. And the cartilage delaminates from the bone, the subcondylar bone. It becomes some pitted area underneath it, but you can see it's loose wallpaper. It's just kind of peeling off the bone itself. That's bad. And this is also other stuff we see here. This is delamination of the cartilage coming off. This is a 23-year-old who came to see a huge amount here. And MRI was small labral tear. And he just had a huge labral tear, huge delamination. And we refixed the back down with 4 or 5 anchors, cleaned up the rim and stuff like that. And he's back to climbing mountains again. Loose bodies, here's another thing we can do. This was a nun that was actually stuck from Eugene down here. She she couldn't flex her hip past about 45 to 50 degrees because of all this mass effect inside her hip capsule. It kind of floated down into the inferior neck, but we were able to get these, 3 by 2 centimeter big osteochondral pieces of Bo's body out, and they look like that. Iliopsoas release. So here's another emerging thing I'm doing quite a bit. I think initially when I started doing this was missing a lot of iliopsoas tendonitis, and this is something I'm seeing quite frequently now, and not only young people but also older people. Older people that have had hip replacements, where they had continued to have pain after having their hip replacements, and the doc can't figure out why, and they're just say you're fine, the hip itself looks fine. Well, it's an impingement, and releasing that tendon can do wonders for them. It's probably one of my most satisfying procedures to get in the right person because they're better with it. I can release it in 2 areas, at the lesser trochanter or kind of an intersubstance type tear. Something I see intraoperatively at the time is actually some labral bruising. Like I said, the iliopsoas runs right over the capsule here in a very anterior medial aspect of the hip joint. When it's constantly popping over, it's rubbing and causing friction right there, which can cause bruising of the labrum. Here it is as it's coming down. This is just as it's going over to the hip joint, so you can see the labrum is going to be right here, which is this aspect. This is an intrasubstance release, so it's right at the level of the capsule here. I'm just releasing this portion and leaving the rest of the muscle intact. I've kind of gone a little bit more away from that nowadays and kind of just doing the full release at the lesser trochanter, which gives me a little bit more full release and less scarring and stuff right at the hip joint where all my other surgery is being done. So here's my surgical plan with FAI. Go in there, I see what the labrum looks like, look at the patient, decide whether to repair it, breed it. Hey, let's look at the articular side, and let's see if the cartilage looks okay, then just kind of clean it up, or do I have to do microfracture that stimulates the new cartilage? They have a pincer deformity where the overcoverage of the acetabulum, do I need to trim back that acetabulum and reaffix the labrum there? The cam deformity, obviously at that point I'm going to do a big osteoplasty, which is kind of like a promeoplasty of the shoulder. Here's the osteoplasty. The joint's actually up here where on the anterior neck as it's coming down. This is that big lesion here that is coming straight out. This should contour back down so I can get in there with my burr and kind of just start taking out some of this bone, recontour it, actually look at it while I'm moving the hip in surgery to see if I've gotten rid of the lesion, whether there's any more pinching on the femoral neck. So here we have it again. The joint's right here. Here's the root of the acetabulum. Here's the edge of the cartilage. Bring it down into extension, look at it, make sure this looks like a nice contour, flex it up, rotate it back and forth, and say, hey, am I pinching anymore? Does it look good? Does my fluoroscopic use look good? Am I happy? Rim trimming, again, this is to recess the anterior acetabular rim if there's overcoverage. I have to take the labrum and displace it, and then I can take my burr, take the bone down here, recess it, take care of some of the damaged cartilage at the edge, and then reattach the labrum back down. So, why are there more people doing this? Well, it's pretty technically demanding due to several things. There's a steep learning curve. I've done 600-700 of these or so. I'm still learning. Still trying to figure out that number of surgeries to do when you actually become really good at this. The other thing, once you get in the hip, and this is my biggest problem, I still see new stuff every time I go in the hip. I say, what is that? That doesn't look normal. What am I going to do about it? How am I going to do it? What's at my disposal? That's probably the trickiest thing. That's why a lot of people may start this once in a while, but to get the number of people to keep doing it constantly is difficult. But the really answer to make why is it hard and make sure your patients are going to have a good outcome is really patient selection. That's just like with every other surgical procedure we do. We look for that perfect person to do. Is our workers' comp always going to do well on this? Probably not. What about this? When I say this patient, I really think they're going to do after a good arthroscopy. I don't know. I really want this patient. The active athletic person who's having hip pain, because I know once I fix them, that they have the drive and they're going to do well. So what do I worry about? What's my biggest thing that I kind of go like, when I see someone come in 16, 17-year-olds that stop their sporting activities because they can't do it anymore. They say, Mom, I'm in pain afterwards. If I get an X-ray to see a huge cam lesion, this is a 17-year-old. If I see this huge cam lesion, that really worries me. Decreased motion on examination, can't do their favorite sports, nothing that stops kids from doing their sports. And when they stop themselves, something's wrong. And this is a huge cam lesion, and put some of his intraoperative pictures in later. So here's a scenario here. This is a labral tear snapping hip. Here we have a 16-year-old dancer. Physical therapy initially helped. They had an iliopsoas injection, tried some conservative treatment. So that helped a little bit for a few months. Came back. They tried the second one. Didn't help the second time. Then she got a hip injection inside of the hip joint. Well, that helped. So now we have two different things going on. Now she can't do any of her activity. She's not doing much athletics. On examination, she does have an impingement sign. Pain is just below the ASIS and a little bit medial. Positive test for the iliopsoas, so having a straight leg raise, active circumduction causes pain. And there's some mild popping of her hip with pain. So here I'm kind of thinking, boy, there's various things going on here, especially with these different diagnostic injections. So when I went in, I wasn't really sure what to find, and interestingly enough, I found both. And this is what I talk about with these being difficult to diagnose and say, is it one or the other? Sometimes it's both. And here we look at her intermedial labrum, again, bruising right here, tearing underneath of it, iliopsoas tendon is right above it. Hers was a very big tear, so I just put one anchor in there, cleaned out the room here, put an anchor in, stitched it down. And then I went to, here's our seal restore, so now I put this hip ball back in the socket and look at the labrum. Now I look at the top of the hip. Here's her hip and extension. As I flex it out, this is what happens. Here's our repair. Same picture. This is what I call a Sharpei dog type look. There's all this extra fibrous tissue that's coming up in there when she was getting past 80, 90 degrees. It was hitting the labrum and tearing it. So I think all this was a result of the iliopsoas tendon rubbing over the labrum, irritating the fibrous tissue, causing hypertrophy. So we found our iliopsoas tendon here and released it. Here's a 28-year-old guy who came in with severe hip pain. Here's x-rays. Again, big cam lesion here. Joint space looks okay. Okay, we got it. So here's his contralateral hip here. Internal rotation, about 30 degrees and about 70 degrees of external rotation. And then we'll take him to a Bader's type test and say, hey, how far are you doing? About a fist and a half or so on that side. Let's look at his, so this is his right hip. Let's look at his right hip. As soon as I flex him up, look, he goes into external rotation. Goes into about 10 degrees of external rotation immediately. And so we'll take him 70 degrees. That doesn't look too bad. Try and internally rotate him. Here we go. Watch his pelvis. His whole pelvis moves. When I try and internally, he's pointing right there. He said, that's where the pain is, and I can guarantee he's cringing when I'm doing that. Especially when I'm doing that, he's squinching his eyes and saying, there's the pain, doc. That's it. Stop doing it. Like that. His Bader's test, he's almost at 3 hands on that side. So here's what his looked like. He had an os acetabular in there, big piece of bone right there from that huge came impingement lesion. This is after we took it out. It was probably about 3 centimeters in diameter. Took it out, the rim's right here. He had just a hugely degenerative tear in there, couldn't repair it. A little bit of delamination here that has to have the rim, special curates and stuff like that to try and clean that out. So here's kind of our post picture. So it looks a lot cleaner now. We don't have loose tissue and cartilage in there. His hip joint itself here, when I look at the back of the sock, I'm looking at the contour like we saw before. I want to see a nice, simple, smooth contour coming down here. You can see it almost has a going sign. It goes down and it goes back up. This is this huge impingement lesion. Again, you see it here, bounce, comes right back up. This one's pretty easy to see. So we take our burr out and we re-contour that. That's it.